I said, clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Clap along if you feel like that's what you want to do. Clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Clap along if you feel like that's what you want to do. I'm losing my self-control. Yeah, you're starting to trickle back in, but I don't wanna fall down the rabbit hole. Cross my heart, I won't do it again. I tell myself, draw the line. And I do, but once in a while I trip up and I cross the line. And I think of you. 2 years are just like that. My head still takes me back. Thought it was done, but I guess it's never really over. Oh, we were such a mess, but wasn't it the best? Thought it was done, but I guess it's never really over. Just because it's over doesn't mean it's really over. And if I think it over, maybe you'll be coming over again. And I have to get over you all over again. Just because it's over doesn't mean it's really over. And if I think it over, maybe you'll be coming over again. And I have to get over you all over again. I guess I could try hypnotherapy. I gotta rewire this brain, 'cause I can't even go on the internet without even checking your name. I tell myself, draw the line. And I do, but once in a while I trip up and I cross the line. I think of you. 2 years are just like that. My head still takes me back. Thought it was done, but I guess it's never really over. Oh, we were such a mess, but wasn't it the best? Thought it was done, but I guess it's never really over. Just because it's over doesn't mean it's really over. And if I think it over, maybe you'll be coming over again. And I have to get over you all over again. Just because it's over doesn't mean it's really over. And if I think it over, maybe you'll be
Can we get the slides up?
over you all over again. Thought we kissed goodbye. Thought we met this time. Was
All right, good morning, everyone. It's after 10, and I want to try to keep us on time because there's an exciting exhibit hall lunch and activities going on, and we want you to get there. So my name is Nancy Albert. You met me this morning. I'm from Cleveland Clinic, and I'm our chair for this session called Turning the Tide on Outcomes, Intravenous Iron for Iron Deficiency in Patients with Heart Failure. And I'm very honored to have two wonderful co-presenters with me today, Dr. Muthu Vadaganthian from Brigham and Women's Hospital and Harvard Medical School, and Sarah Paul, who probably needs no introduction, formerly at Western Piedmont Heart Centers in Hickory, North Carolina. So I'm going to do a few housekeeping things first, and then we'll jump right in. So I'd like to thank American Regent for providing independent educational support, and the program management services are being provided by Vox Media. Please keep the brief questionnaire from the staff at the end of the session. Attendees may earn continuing education credit just by filling out your evals for the annual and the meeting sessions. There are going to be question cards that are going to be sent around that can be distributed. If you have a question, we really welcome questions, and we've purposely set aside time for Q&A. So somebody will come along and collect those cards and hand them over to us so we could ask questions of our esteemed panel here. If you've got a cell phone, please put it on silent mode. And something to note, right outside of the ballroom, right on the right side of the last door is a table, and on the table there's a QR code, and that QR code will give you access to the slides if you're interested in seeing the slides from this presentation. And then keep in mind that the staff are going to ask you to fill out a brief questionnaire at the end of the session. So with that, our first presentation is on iron deficiency and heart failure, clinical prognosis, and the need for diagnosis. And Dr. Muthu Vadiganthian is going to present.
Excellent. Thank you, Dr. Albert. Thank you all for joining at this early hour. My name is Muthu Vadiganthian from the Brigham and Women's Hospital and Harvard Medical School. And it's a privilege to be able to talk on a topic that I think is central to our own practices and is of growing importance at the national and global level. I'll start by sharing my disclosures and set the stage for the diagnosis and the prognosis associated with iron deficiency. Why is this such an important concept to grasp, test for, and treat in our own practices? So iron is a beautifully regulated compound in the system and is ingested in a toxic form, in ferric form, that's rapidly converted to a ferrous form that can actually be absorbed. The absorption, metabolism, and utilization of iron subsequently is orchestrated tightly by a number of key enzymes and processes. So in the gut, in that ferrous form, ferrous iron is subsequently transported by ferroportin and other enzymes and ultimately is then mobilized into the system. Iron is subsequently then stored in key tissues in the form of ferritin and then can subsequently be used when needed for either erythroid production or non-erythroid-based aerobic metabolism. Importantly, there's a key enzyme here I'd like to note is hepcidin, which we'll talk a lot about today. Hepcidin is a master regulator of iron and is able to actually serve as a check and balance. And in the setting of inflammation particularly, hepcidin levels are quite elevated and may block that metabolism step and transportation of iron. So what is the burden of iron deficiency at the national level? As with any entity, epidemiology is really critically based on definitions. And here we use the definition that's most commonly employed in guidelines, which is a ferritin level less than 100 or 100 to 300, so a bit more liberal, with a TSAT less than 20%, and we'll review that. And even taking a very conservative lens, in a relatively stable ambulatory population, upwards of 40% to 50% of individuals have comorbid iron deficiency. And you can see here that as you move up to more severe functional classes, NYHA class 3, 4, the burden of iron deficiency actually is more substantial. And with NYHA class 4, we have upwards of 60% comorbid iron deficiency. This is the spectrum of various epidemiological investigations using real-world evidence, trying to estimate that burden of iron deficiency, moving from chronic heart failure, at the far left, to acute decompensated high-risk individuals in the hospital, as well as in the near-term post-discharge setting. And you can see there that same window of about 40 to 60% in the chronic ambulatory setting. However, when we move to the acute decompensated heart failure setting, it's even more substantial, with almost 3 out of 4 individuals with comorbid iron deficiency, and that persists in the post-discharge window. Iron deficiency comes in 2 main flavors. That's absolute iron deficiency and functional iron deficiency. As a cardiology community, as a heart failure community, we're going to be more discussing functional iron deficiency. When we think more generally about general medicine, especially about gastrointestinal disease, we're thinking more absolute iron deficiency. So what are these 2 entities? Absolute iron deficiency is a pure reduction of iron stores. So this might be due to increased losses, like chronic blood loss, or reduced absorption or reduced intake of iron. Think malnourished states. This is critically defined simply by a low serum ferritin level that's critically low, below 30. Functional iron deficiency may be in the presence of normal iron stores, a normal or even elevated serum ferritin level. However, due to chronic inflammation, that iron is unable to be utilized, unable to be metabolized. And so functionally, you may actually end with the same result in impaired key metabolic pathways. The key syndromes here that are associated with functional iron deficiency are very familiar to this community: heart failure, chronic kidney disease, syndromes that are associated with systemic inflammation. The diagnoses are not only based on serum ferritin, which has more liberal criteria, could be in the presence of normal or normal serum ferritin levels, but is defined by a transferrin saturation less than 20%. So our transferrin, which is the actual transport protein, is not able to be sufficiently saturated because of that inflammation, because of the impaired metabolism. So let's visually take a look at this. So absolute iron deficiency can either be due to, you can see, reduced intake, malnourished states, reduced absorption for various primary gastrointestinal issues or issues with the duodenal mucosa, or increased losses in people, for instance, on antithrombotic therapy, antiplatelet therapy, with increased GI losses. The resultant issue is that transferrin's unable to, because of insufficient intake or increased loss, is not able to deliver sufficient iron to stores or to key tissues that are using iron. And so our storage pool is reduced, and then our functional pool, the pool that we use for key enzymatic processes, is also reduced. Functional iron deficiency is a bit more complex. Here, we may have normal intake, and in the presence of cytokines, particularly modified by inflammation, we have increased levels of that key regulator, hepcidin. And hepcidin then prevents the transportation of iron from the gut, out of the gut into storage pools or into key metabolic pathways. And so here you have maybe a normal storage pool because you have sufficient intake, you're not having excessive losses, you have a normal storage pool, but your functional pool is unable to be used because hepcidin is serving as a key blockade to the actions of transferrin. So I'm going to shift a bit to broadening our lens in recognizing that iron deficiency has always been closely associated with the term anemia. And often, we as a community use iron deficiency anemia and iron deficiency as synonymous terms. But in fact, these are distinct entities that each have important consequences to the biological system. So iron deficiency may impact biology and health outcomes independent of the presence of anemia. Of course, iron is a critical element that allows for the synthesis and production of erythroid cells and hemoglobin. However, even beyond that, it's involved in a number of other tissue processes, mitochondrial functioning, tissue remodeling that iron is specifically used in, including the myocardium, may actually be involved in processes that modify functional status and exercise capacity, may have also cognitive effects, and then we may even see with the data direct morbidity and mortality information independent of the presence of anemia. So I like to think of this as a branched entity in which you certainly have an effect on hemoglobin production and anemia, but you also have impairment of key aerobic enzymes that are involved in oxidative phosphorylation and that impair oxygen utilization in addition to oxygen delivery, which is modulated by hemoglobin. And so together, these really cause a profound impact on the human system with a reduction in tissue energy and performance status. And the data does suggest that these theoretical concepts of systemic effects do bear out. When we look at sensitive measures of health status, for instance, the Minnesota Living with Heart Failure questionnaire for quality of life measures, we see even in the absence of anemia, there's an impairment in health-related quality of life in people with iron deficiency. Furthermore, there's a prognostic impact even independent of anemia. So if you look at the left hand, this is purely now non-segregated by anemia status. People with iron deficiency have worse outcomes. However, more importantly, in this sample of 1,500 patients, on the right hand is a key concept. You have prognosis that worsens as you move up this chain, and the best prognosis is people without anemia and without iron deficiency. The worst prognosis is people with comorbid iron deficiency and anemia. But there's a gradient in between. Even people, and you highlight in the box there, even people with iron deficiency in the absence of anemia have worse prognosis in terms of all-cause mortality compared with people without iron deficiency. So clearly suggests that iron deficiency is a targetable entity independent of the presence of anemia. So that epidemiological estimate's about 25 to 40% of people in the absence of anemia may have iron deficiency. So important to screen broadly, and in fact the ACCHA and the ESC guidelines recommend routine screening for anemia and iron deficiency on diagnosis and with substantial clinical changes at least annually. And in broad populations, we've talked about select cohorts. In the US national level, even using Medicare data, suggests that about 50% have anemia, and those patients clearly have a high burden of iron deficiency, but you see there, even people without anemia have a substantial burden of iron deficiency, and that's associated with long-term prognostic impact. So the definition of iron deficiency, I just want to spend a clear moment on, because the guidelines clearly suggest that serum iron, transferrin saturation, and serum ferritin are the key investigations that should be tested routinely in practice on diagnosis and at least annually. And to diagnose absolute iron deficiency, really we only need a low serum ferritin. It's often in the presence of low iron and low transferrin saturation. Functional iron deficiency can also be essentially diagnosed with low transferrin saturation, and certain risk factors, including women, advanced heart failure status, recently hospitalized individuals, or high inflammatory markers might also trigger you to suggest this person is certainly at risk for iron deficiency. And here are those guidelines. You can see here that it's a class 1 recommendation, and this is in the routine workup of an initial diagnosis of heart failure. And furthermore, the periodic screening of iron deficiency in the ESC guidelines here, again, a class 1 recommendation inclusive of those two key elements, which is serum ferritin and transferrin saturation. So in the closing slides here, I'd like to suggest that despite, I think, the importance that I hopefully have highlighted, we have vast underdiagnosis and undertreatment in practice. This is a recent large-scale investigation in which there was about 10,000 admissions for heart failure, so our highest risk group of people for iron deficiency. Unfortunately, only about 1 to 2% were tested, and of those, only about a fifth, even of those who met iron deficiency criteria, received IV iron appropriately. So as a key functional pathway here, in a person you suspect has iron deficiency, or when you're routinely testing, check a serum ferritin, check a TSAT level, or transferrin saturation level. If the level is markedly reduced, less than 100, then the person likely has absolute iron deficiency. That's when you look for instance, other causes of iron losses, colonoscopy screening, targeted investigations in terms of history and physical for blood loss or malnutrition. And then subsequently, if someone is also markedly anemic, check for those alternative sources of loss or reduced intake. And then if those are not present, especially in the presence of functional iron deficiency, then you can treat with IV iron. This is the last slide, and it's not meant to be really read verbatim here, but the concept is that as with any definition of an entity, it isn't one in evolution. And while I've given you some cutoffs to work with, we as a community are rethinking how we diagnose iron deficiency. We're going to soon review the data to support why IV iron is so impactful in people with heart failure. It seems particularly impactful in those with purely reduced transferrin saturation levels, less than 20%, independent of ferritin levels. So there have been some recent discussion in the academic community about whether we should simplify our definitions of iron deficiency and move towards a transferrin-only approach, at least in our patients with heart failure, to diagnose actionable iron deficiency. So that's a work in progress. The guidelines have not yet changed. What I shared is what is mentioned in the guidelines, but in case you hear more, I wanted to give you that introduction. Thank you so much.
All right, I'm gonna just move this over so I could see my slides. I'm too short to stay behind the podium. I'm gonna talk about exploring the evidence with iron supplementation and heart failure, and we only have 15 minutes, so it will be a broad overview, but please let us know if you have questions. We're very happy to answer them as we go along here. So here you could see my disclosures. And so the first question is oral iron therapy. Does it work, right? And so, remember that oral iron preparations are usually in the ferrous form, and the absorption rate may be lower than you think if you never read the literature, about 10 to 15%. And ideally, patients should be taking it 30 minutes before meals so that it can be absorbed better. But in some of our patients, there's side effects, and not everybody tolerates it well. They may feel that metallic taste in their mouth, they may have nausea, abdominal bloating, flatulence, diarrhea, constipation, and it leads a lot of people to discontinue it. If the hemoglobin is, if there's an increase in hemoglobin and the reticulocyte goes up within 1 to 3 weeks, it does indicate success. And as Muthu talked about, we know now that hepcidin can get us into some trouble with it, and patients with heart failure tend to have inflammation. And I'm going to show you a slide here in a minute about giving us a better clue about why maybe oral iron doesn't work in a lot of our patients. So this is the Iron Out study, and this was published back in 2017. So it was done even before and at the time the iron IV supplements were just getting started. And this is a phase 2 study, and you could see that the patients had to have HFrEF, and they were New York Heart Association functional 2 and 3, so symptomatic heart failure. And you could see what they looked at to see if patients met the criteria. The ferritin had to be between 15 and 100, or it could be less than 300 if the TSAT was under 20%. And again, they weren't looking for people with absolutely beautiful hemoglobin, so the hemoglobin had to be in the normal or a low range, and the primary outcome was peak exercise capacity. And patients were studied at 8 weeks and then again at 16 weeks. And if you look at the slide on the left, you could see the oral iron is in red and the black is the placebo, and you could see there was not a statistically significant improvement in that primary endpoint of peak oxygen changes. And if you look at the top on the right side, you could see just looking at a change in ferritin over time didn't really change that much either. Yes, it was slightly uphill more than the placebo group, but really not very much of a change at all. Didn't really get above 100. And if we compare that to the FAIR heart failure trial, which was a very early iron supplementation trial using ferrocarboxymaltose, you could see in the red that at 24 weeks, there's a huge improvement in the ferritin level. And when you compare it to Iron Out, you could see that oral iron just doesn't cut it these days. So oftentimes we're trying to look at why, and again, you already heard about hepcidin and where it's synthesized and how it affects our patients. And again, remember that in patients with a chronically elevated pro-inflammatory condition like heart failure, they may be in trouble. And you can see if you look at the left part of the figure that in patients who had the hepcidin level changed into quartiles, and for patients in the third and fourth quartile with higher levels of hepcidin, they were more likely to have less change after getting oral iron in terms of iron bioavailability. So their T saturation level did not change as much in those patients. In the middle part of the figure, you're looking at cellular iron levels, and again, you could see that the cellular levels didn't really change at all from baseline in the patients with the high hepcidin levels. And if you look at the right part of the figure, now we're looking at iron stores. And you could see with people with lower hepcidin levels, so less pro-inflammatory state with their heart failure, the levels went up more and they didn't really go up. The ferritin didn't change that much with the patients who had high hepcidin levels. So then we move into early iron research, and I'll just make a comment about the last slide. And again, there's no strong evidence for this, but it's just what I see in my practice. If I have a patient with a high N-terminal pro-BNP, and I tend to offer oral iron first because it's cheap and it's over the counter, and I will tell you almost everybody that I offer it to that has a high N-terminal pro-BNP, I see no change in their outcomes. If somebody's got a normal N-terminal pro-BNP, their heart failure may be persistent and they have low symptom burden, they may not have as much pro-inflammatory cytokines running around, and those patients may have improvement with oral iron. But a lot of our patients that are symptomatic, functional class 2 and 3, are having more problem with that. So let's look at the early IV iron research. The FAIR heart failure study was a 24-week outcome study, and confirmed heart failure occurred after that, and that was a 52-week outcome study. I'm putting them both together, though, because they had very similar entry criteria. You had to be functional class 2 or 3 heart failure. They were both small studies, around 300 patients. In FAIR, you had to have an EF of 40% or less. In confirm, it was up to 45% or less. And the serum ferritin and TSAT requirements were the exact same, less than 100 of ferritin, or if you are greater than 100, it could be less than 300 with a T saturation of 20% or less. Hemoglobin levels were, again, in the normal to low range. And they both used ferric carboxymaltose as their IV ferric solution. And you could see the outcomes were a little bit different in each study. The FAIR study looked at quality of life, and again, they looked at it in many ways: Kansas City Cardiomyopathy Questionnaire, the European version of the EQ5D, and they even did a patient global assessment. They also looked at New York Heart Association functional class and 6-minute walk test. On the confirmed side, similar outcomes, but now they added on a secondary outcome, time to first heart failure hospitalization. So they got a little bit more rigorous with the outcomes. Now, I put in green all of the outcomes that were statistically significant in each of the trials, and you could see that for both studies that most of the outcomes were statistically significantly improved in people who got the IV ferric carboxymaltose compared to the placebo. And in the FAIR study, they started seeing positive outcomes in as little as 4 weeks after getting the drug therapy. And the trend even improved for an increase in eGFR that was maintained at 24 weeks. That wasn't one of the primary outcomes, but it was an observed outcome when they were studying the patients. In the confirmed heart failure study, they again started to see outcomes at 12 weeks and 24 weeks, and it was maintained over the whole 1-year period. So this was a longer study. And what I want you to see on this slide, if you look at the ferric carboxymaltose column in the middle and the placebo column a little bit to the right, first of all, if you look at number of patients with endpoint or event for each of the two groups, the ferric carboxymaltose and the placebo group, you'll see that any cardiac disorder that was considered an adverse event was less likely in the IV ferric carboxymaltose group, 27.6% versus 50%, not quite double in the placebo group, and that that was statistically significantly different. All of the other side effect profiles, many of them had very small numbers, 0 out of 10, 9, so very small numbers, and you could see there was no differences between groups. So in general, from an adverse event profile, less cardiac disorders in people who did get the IV therapy, and very few side effects. And here on the confirmed side, you could see the adverse events as well. And you could see if you look at subjects with at least one adverse event and on down the line, they're very similar between groups. And so there's not a lot of differences in terms of adverse events when we give these IV solutions to our patients. So intravenous iron preparations are well tolerated, and again, they don't rely on hepcidin-dependent absorption. And because they don't rely on hepcidin-dependent absorption, it is now evident that in our patients with heart failure who are in pro-inflammatory states, that IV preparations may be better. So let's look at more newer studies. So on the left is AFFIRM acute heart failure, and on the right is Ironman. And both of these studies were launched right before COVID, and then COVID came along. So what I want you to see here is the definition for iron deficiency is the same. It's in the little green box at the top. And if you look at the AFFIRM acute heart failure study, you could see that these studies are bigger now. We have 1,000 patients instead of 300 patients. And hospitalization for acute heart failure, again, they were all hospitalized for acute heart failure, and we studied total HF hospitalization and cardiovascular death. And you could see that the p-value is just outside of what we would call statistically significant. But you could see over time, after especially the 12-month period, the curves start to separate in favor of the ferric carboxymaltose. They ended up doing a covert sensor analysis because of patients dying from COVID and being hospitalized because of a COVID complication, and I'll show you that in 1 minute. On the Ironman side, again, you could see that the initial p-value was 0.07, so again, just outside of what we would consider statistically significant. But again, you could see the curves start to separate more quickly in this group of patients. These patients got ferric deoxymaltose instead of ferric carboxymaltose, but very similar compound. And again, we saw nominal reductions in heart failure hospitalization once the COVID-censored analyses were completed. So if you look at the AFFIRM heart failure, now you could see the p-value is statistically significant, and there was a 26% reduction in heart failure hospitalization. So when they looked at hospitalization and death together, it seemed like the biggest evidence was in the heart failure hospitalization arena. On the Ironman side, when they looked at hospitalization for heart failure, stroke, MI, or cardiovascular death, again, now you can see that the p-value is statistically significant once they did the COVID-censored analysis. So we started seeing that we were getting more important outcomes, not just how you felt, and could you walk further in your 6-minute walk test and reduce your quality of life better, but now we're starting to see the improvements. And then the bigger study that was done in the United States by Rob Metz and his group out at Duke was the HeartFit study. And we were all excited about this study because it was a larger study. Now you could see 3,000 patients, not 1,000 patients. Patients were 1-to-1 randomized. They had to have HFrEF. And they, again, now could have functional class 2 through 4. So again, symptomatic heart failure on maximally tolerated medication regimens. And you could see the hemoglobin hematocrit criteria, the criteria for ferritin and transferrin saturation was exactly the same as what we had seen previously. They had to be hospitalized for heart failure within 12 months or have elevated natriuretic peptide levels. And now you could see that the primary endpoints are 1-year death, 1-year heart failure hospitalization, and change in 6-month 6-minute walk test. And then they also had some secondary endpoints. Now, most of these studies that were done had similar drug administration for ferric carboxymaltose. So I put it on the slide for those of you that are not familiar with the typical ordering strategy, and that is 2 doses of IV solution, 15 milligrams per kilogram, to a maximum individual dose of 750 milligrams, 7 days apart for those 2 doses, and a maximum combined dose of 1,500 milligrams. And that could be repeated every 6 months if needed. In much of the research, though, they found that it didn't need to be repeated in many patients at the 6-month level. So what did they find? Well, they did a win ratio analysis instead of the typical analyses that we see in many of our studies. And the win ratio p-value was targeted at 0.01. And their actual p-value was 0.019. So they didn't meet the outcome criteria. When they looked at wins versus non-wins, they saw that they did have a 10% increase in wins in giving the ferric carboxymaltose versus placebo, but again, it did not reach statistical significance. When they looked at the primary outcomes and broke it down by some of the different factors in the outcomes, you could see that 12-month all-cause mortality was lower, a 17% absolute risk reduction, so 20% more wins. When they looked at total heart failure hospitalizations at 12 months, again, we could see the difference in wins, and you could see the increase in 6-minute walk test over time as well. So where are we at today? Well, very nicely, we had in January of this year, a meta-analysis was completed, and it was published in the Journal of American College of Cardiology. And what they did is they created these little CV death as the rest in peace and a little hospital sign for heart failure. And if you look at the bottom row going across, you could see that the odds ratio, putting these studies all together as a group, for a decrease in cardiovascular death was about a 13% benefit for patients getting ferric carboxymaltose. If you look at cardiovascular death and hospitalization, it was about a 16% improvement. If you look at first heart failure hospitalization, it was a 15% improvement. And if you look at total hospitalizations over the study period, it was now getting more robust, and you could see the relative risk is 0.739, so about a 26% relative risk reduction. And interesting, they did a meta-regression, and they learned that if your TSAT was less than 20%, irrespective of what your ferritin level was, those are the patients who did best. So Dr. Vadiganthian just talked about looking at TSAT as the outcome of interest, and that's the lab value of highest interest for us, and we were seeing that even in this meta-regression. So again, he already showed you the recommendations for ACC and the European Society, so I won't go into that again, and I'll just give you these key takeaways. The first one is that IV iron repletion with ferric carboxymaltose or ferric deoxymaltose compared to placebo does reduce the risk of recurrent heart failure hospitalizations and cardiovascular death in patients with heart failure and iron concerns. And a lower baseline transferrin saturation of less than 20% may be the important ticket here for the effects that we want to see in our patients in terms of heart failure events. Giving these drugs are safe, and again, in heart failure ref especially, if IV iron deficiency is appropriately and promptly diagnosed and managed, again, we have a strong potential to improve the way patients feel. Their symptoms will improve, less dyspnea, less fatigue. They'll be able to exercise more, and again, we'll see these potential outcomes of cardiovascular death and hospitalizations improve. And so it's up to us as multidisciplinary teams and interprofessional teams to facilitate how we get our patients diagnosed quicker, how we get the necessary follow-up testing, get them into a clinic because it could be done ambulatory. You do not need to bring a patient into the hospital for this, but setting up the right program so we can get our patients in for the 2 treatments of IV treatment for ferric carboxymaltose. So with that, I'll stop, and I'm very excited about Dr. Sarah Paul's presentation. She's going to talk about best practices for managing IV iron deficiency in heart failure, and she's got a lot of pearls to share with us.
Thank you, Nancy. I can stay behind the podium and see the slides. All right, so I am going to offer some practical application in the clinic and in the hospital to for patients who are iron deficient with a case study. So this is a 72-year-old woman who weighs 80 kilograms. She was admitted to the hospital with complaints of shortness of breath and edema and fatigue that had been coming on for about 2 months. She had an echocardiogram that showed left ventricular ejection fraction at 22% and a dilated left ventricle with moderate functional mitral regurgitation. She was not found to have any significant obstructive coronary artery disease, so she was diagnosed with idiopathic dilated cardiomyopathy. She had a history of hyperlipidemia, gastric reflux, and she was a smoker, but she quit smoking 25 years ago. Her renal function was normal, which makes her an outlier among most of our patients. Renal function was normal, mildly elevated lipids. BNP was 1,200 on admission, but it was 240 by the time of discharge. Hemoglobin 12.1. Serum ferritin was very low at 10, and TSAT was also low at 11%. She was diuresed in the hospital, and guideline-directed medical therapy was initiated and up-titrated as much as it could be within the hospital, and she was discharged to home on the following medications: carvedilol, 12.5 milligrams twice a day, sacubitril valsartan, 24-26 twice a day, spironolactone, 25 milligrams once a day, furosemide, 20 milligrams daily, empagliflozin, 10 milligrams daily, rosuvastatin, 20 milligrams daily, and omeprazole, 20 milligrams daily. So as I go through this case study, I'm going to have our panelists discuss elements of this. So I have a question for the panel here. Is this the time to initiate iron treatment? Should we wait until the outpatient follow-up? What dose would you start at? Oral versus IV?
So at our center, our physician providers prefer that we start with oral and see how patients do. Although that is not always the right answer, as I'm learning, because these patients have not been improving. I've got 3 patients right now that are waiting for me to switch to ferric carboxymaltose. We just got it on our formulary within the last month, so it's a brand new change that we're now able to offer this therapy to our patients. So we were always trying to start with oral first because our other alternative was IV sucrose, and we just didn't like the side effect profile, et cetera, from IV iron sucrose. But I think this very low TSAT of 11% means that maybe if, knowing that I have the ability to prescribe it, I would probably go straight to IV ferric carboxymaltose.
Yeah, and I tend to agree, and the only addition is with the markedly low serum ferritin, you are interested to also pursue other diagnostics for especially GI-related losses. And the formulations are going to vary based on hospital availability, but in our center, we do certainly preference IV iron. However, we don't have some of the studied therapies on our formulary, and so we end up using alternative IV iron formulations that are available that are generic.
All right. So this patient, well, let me just say the Heart Failure Society of America has developed a scientific statement, and if you haven't read this, it was published in the Journal of Cardiac Failure, and I'd highly recommend taking a look at this article. So if the patient is symptomatic with heart failure and ejection fraction below 45%, and they have a hemoglobin below 15, then they should be evaluated for anemia. If they are anemic and they have some acute event occurring, then that should be treated. But if they do not have an acute event and it is possible that iron deficiency is the cause, then you should evaluate iron studies. And if the ferritin, as Nancy and Muthu have alluded, if it's under 100, or if the ferritin is functionally low, between 100 and 299, plus a TSAT that is less than 20%, if all of that is stable, then that should be looked at least annually in our heart failure patients. If they do have low ferritin, low TSAT, then we would calculate their iron deficit using the Ganzoni formula, and I'm going to show you that in just a moment. And then it can be given, as Nancy said, inpatient or outpatient, which is the beauty of IV iron. And it should be repeated. Once the patient's iron is repleted, it should be repeated 3 to 6 months later. So the Ganzoni formula is, as you can see, this equation that uses the patient's body weight and their actual hemoglobin to calculate. So our patient weighed 80 kilos, And the target hemoglobin is 15, that's a standard. Her actual hemoglobin was 12.1, and her iron stores, the goal is 500. So her deficit was 1,057 milligrams. Now, I know you're going to be carrying this in your pocket, so you can go calculate this in the clinic or on the floors, but you don't need to because the dosing really is pretty standardized. So for ferric carboxymaltose, which is currently the only IV iron that is approved for heart failure indication, is again based on the weight. So the initial dose, our patient was greater than 70 kilos, but her hemoglobin was less than 14. So she received a dose of 1,000 milligrams IV ferric carboxymaltose. And you can see most of the doses are 1,000 or 500. Now, I've been using this for years, this particular drug, in my patients, mostly based on anemia because we didn't have all this data about iron deficiency. And traditionally, those of you who have been giving it probably gave, I think it's 750 milligrams once a week for 2 weeks, 2 doses a week apart. But you'll see this dosing is a little bit different than that. So it's 1,000 milligrams based on the patient's iron deficit. So 1,000 milligrams is what this patient received for her first dose. Now I want to talk, Nancy gave a very nice presentation about oral iron and the decreased absorption, but there are many things that decrease absorption of oral iron. One is gut edema. The patient's not able to absorb, and our patients have gut edema. Hepcidin, I Googled it while I was sitting here and it said hepcidin, so tomato. Hepcidin is increased when cytokines are increased. And we know that in our patients, they have elevated levels of cytokines. And hepcidin can block the intestinal absorption and also the mobilization of iron. So this can decrease absorption as well. Polyphenols that are found in some foods, such as teas, coffee, wine, legumes, cereals, fruits, vegetables, can also decrease the absorption. And this is the big one right here. Proton pump inhibitors and histamine H2 receptor blockers can decrease the absorption. Now, if you think back to nursing school, we were taught that we were told to give patients their iron tablet on an empty stomach with a glass of orange juice to increase the acidity of the environment for better absorption. But I could probably count on one hand the number of patients I've seen in 30 years who are not on a PPI or an H2 blocker. So almost everybody seems to be on pantoprazole, omeprazole, one of these drugs. And they're probably every morning taking their iron pill with their omeprazole or their pantoprazole. And so they are not absorbing. And I'll tell you right now, primary care providers are not in tune to this. So leave here and educate your primary care providers about this, about the decreased absorption of oral iron and also about the inhibition from PPIs and H2 blockers. And so I went to Google Scholar just to do a quick lit search and see, well, this didn't show up very well, but it's a whole list to say, well, you know, what are the effects of PPI and H2 blocker on oral iron absorption? And this was only page 1, which was a full page of studies that had been done that showed that these drugs decrease the absorption of oral iron. So go out and spread the words. Can I hear an amen? Amen. All right. So this patient was seen in her post-hospital clinic appointment. She was stable, she was euvolemic, she was mildly symptomatic. Her medications had not really been changed, except her spironolactone was increased to 50 milligrams due to mild hypokalemia. She was still short of breath, mildly, with exertion, and she had fatigue with her activities of daily living. Her 12-week follow-up echo showed an ejection fraction of 30%, so it was better, but not where we would like it to be. And she was New York Heart Class 3. She still had good renal function, BNP was stable, hemoglobin 12.3, serum ferritin and TSAT were improved, but ferritin is still under 100, TSAT was 19%. So she's on the same medications she was discharged because hypotension prevented further up-titration of her medications, with the exception of the increased spironolactone. So panel, now what? Her iron, her ferritin, and her TSAT are much better. They're not at the cutoff point that we were looking for. Does she need further treatment?
Yes. So perhaps I'll start just broadly speaking. This is so humbling, I think, as a heart failure clinician, as a researcher, that she really is on guideline-directed medical therapy, on quadruple therapy at maximally tolerated doses. She has essentially normalized her natriuretic peptide levels, and she has normal kidney function, normal end organ function otherwise. And it's humbling that she still has symptoms post-discharge. Her ejection fraction hasn't normalized. And this does suggest that addressing quality of life and functional capacity may be another dimension beyond what we traditionally have used as kind of the core pillars of therapy that often address morbidity and mortality, but still patients face a tremendous burden of residual symptoms. So this is a 12-week window, and the exact time frame in terms of when we consider redosing is, I think, variable, but generally the 3 to 6 month mark is in a person who still meets iron deficiency criteria should be redosed to reach target. So this is a unique therapy in that it's unlike our other elements of guideline-directed medical therapy where we sort of start it and we're not necessarily targeting anything particular, we're starting it as a core pillar. Here, we're actually treating to target, and that's also a key educational issue.
So I agree with that, but I would also look at down the road, you know, she's still symptomatic, her EF is still low, and her carvedilol dose could probably be up titrated. So unless she has a problem with going higher because of a low heart rate or some other problem.
Hypotension was the only thing.
Okay, even for the carvedilol, I thought that was for the sacubitril valsartan.
That was for all of it.
For both of it?
Low blood.
Okay,
Yeah.
all right. Well, then it seems like, and then the TSAT of 19% is still very concerning to me. So
Okay.
The fact that the ferritin went up is great, and it probably will continue to go up over time if you just waited on its own, but the TSAT is still less than 20%, so I would say this patient would need some treatment down the road. Whether you do it now or wait a little bit would be.
Okay, so she was retreated, this time with 500 milligrams of ferric carboxymaltose. And at her 24-week reassessment, she was stable, she was class 1, she was really doing very well, and repeat iron studies showed serum ferritin was 91, so as you said, it continued to come up. TSAT 28%, hemoglobin 13.7. Okay, now what? Does she need more treatment? And if so, what dose? Ferritin is still under 100.
Good.
Go on.
This
That
is
was good.
this is clearly kind of a
funny.
borderline issue, but I think most people in this scenario, in the absence of any other losses, I think would probably continue to treat. If we do move to a kind of a transferrin saturation only approach, which might be in our future, then she is sufficiently repleted, and so this is a kind of borderline.
Okay, all right.
So, and my comment was going to be similar. The TSAT's above 20%, and based on the meta-regression that was just done recently, I do think we need to have more research and better understand the bigger picture. But based on this and the fact that she's now New York Heart Association Functional Class 1, she's not going to get the benefit of improved symptoms because she already has improved. I probably would let it sit and just reassess her in 3 months instead of waiting 6 months to see how she's doing.
Okay, all right, that's reasonable, but we treated her with 500 milligrams. And there's still some gray area, as
That's
you
right.
said. It's not entirely clear just yet. All right, so then at 36 weeks, all of her iron parameters were normal. And she felt good, she was doing well. So now, how frequently should this be monitored? I think you've addressed that. But now that her iron has been repleted, should we put her on an iron supplement? And conversely, if you see patients in the clinic who are on an iron supplement, should we stop it and just send them for IV iron? What are your thoughts?
You know, it's, I think in theory and based on the evidence, I'm not seeing any sufficient benefits of oral iron supplementation. Often patients are trying to pare down their regimens, and I often use this as a way to barter with patients in terms of, I'll remove this therapy, but we may need to add element of guideline-directed medical therapy, and that often is a successful negotiating approach. But I think Nancy had mentioned, there are patients who are entirely stable and who we believe have capacity to absorb iron. So they have kind of no indication of high-risk features of systemic inflammation or elevated natriuretic peptides or instability. In those patients, I think continuing is reasonable, especially if they've had sufficient responses. Mm-hmm. It's not that oral iron doesn't work at all. It is that the repletion takes so long and has so much complexity in terms of intolerance, drug-drug interactions, complexity of oral dosing, that it often in practice is insufficient to replete a patient. So in a person who is sufficiently repleted on oral iron, I'll continue it, but I won't start it as a primary method to replete a patient.
Okay.
And I will say I have had a few patients, because our provider's philosophy was to start the oral therapy first, that actually did beautifully well, but I have more patients that did not. So, and I didn't really, initially I couldn't tell who was gonna get better and who wasn't until I started noticing that the pro-inflammatory state, I think, makes a big difference. Mm-hmm. We don't monitor, IL-6 and some of the other inflammatory markers as a routine way of assessing our patients. But we could look at the patient's symptoms and how symptomatic they are, what's going on with their BNP, which is not truly an inflammatory marker, but it does tell us about wall stress, which can lead to inflammatory states. So I think if we just look at the big picture, we'll have a better understanding of, do we treat them with oral first because it's cheap and it could be effective for somebody, or do we just jump right into the IV scenario? And of course, if the oral doesn't work, you're gonna know it within a very short period of time. I never go more than 3 months without testing them and then bringing them back in and talking about the next steps.
Okay, so I'm gonna just move through this quickly because I see there are some cards with questions. So, contraindications to IV iron: hypersensitivity to ferric carboxymaltose or any of the inactive substances in it, or hypersensitivity to any other parenteral iron products is a contraindication. Of course, anemia that's not attributed to iron deficiency would be a contraindication. And evidence of iron overload or some disturbance in utilization of IV iron, of utilizing iron. Precautions that we should take are patients who have an infection or patients who are prone to infection, because it turns out that iron is an essential nutrient for bacteria. So if the patient is bacteremic, or if they are at risk of bacteremia, or if they develop an infection, the iron should be withheld. Patients with known drug allergies, especially people with severe asthma, eczema, or other types of allergies, could be more prone to hypersensitivity. Increased risk of hypersensitivity is also seen in patients who have immune or inflammatory conditions like lupus or arthritis. There is no evidence at this time that ferric carboxymaltose in patients with HFpEF is a reasonable treatment at this time. Ferric carboxymaltose has not been evaluated in patients with a hemoglobin over 15. This can be given inpatient or outpatient. If it's given IV, it needs to be diluted in a smaller amount of volume, no more than 250 milliliters. It should be given over about 15 minutes, so it's a slow IV infusion. It can be given IV push, but it means a nurse standing there slowly pushing it over a course of several minutes. It is stable at room temperature for 72 hours, so if the patient can't get to their outpatient infusion that day, they can come the next day or so. It should be okay if it's already mixed. It doesn't have preservatives, so if it's off color or if it appears with granules or any kind of particulate, and each vial is only a single dose vial. The patient should be monitored briefly after they receive the infusion. If they're going to have a side effect, it's going to be pretty quickly after the infusion is completed, or at least after it is started. The patient should be rechecked, let's see, at least annually if they're stable. And some of the side effects you might see are trunk arthralgias, myalgias, or flushing. They can have symptomatic hypophosphatemia, and these are the risk factors for that. The patient should be monitored at least 30 minutes for any kind of hypersensitivity reaction, and their blood pressure, their systolic pressure might go up right after the infusion, but it will come back down, but they need to be monitored. And it's important to make sure the patient knows this does not mean they stop their guideline-directed medical therapy. This is in conjunction. They continue with all of the medications as they have been on. Okay.
All right, thank you. We do have a few questions. I'm watching the clock, and I realize we only have a few minutes here, but I'm going to have at least 3 of these questions answered just because I think they're really important. Do you want to start with yours?
Sure. There were several questions around heart failure with preserved ejection fraction. Of course, is a growing group of patients that we take care of. There have been smaller studies that are either ongoing or recently completed, one of which was presented at the European Society of Cardiology heart failure meeting called AAHFN. Unfortunately, the trial only recruited 42 of the planned 200 patients. However, there were signals of improvement in these patients with improvements in 6-minute walk distance. There was no changes in patient global assessment or quality of life, but I think it certainly suggests that this is an area of ongoing study. There's a couple of other clinical trials also under investigation. So at the present time, we still primarily treat people with reduced ejection fraction, but it's an area of ongoing investigation.
And when the American Heart Association revised the guidelines, they chose not to, or I'm sorry, when the FDA approved ferric carboxymaltose, they chose to approve it without indication of EF. So the approval from the Food and Drug Administration is you could use it in any form of heart failure. So it could be HFrEF, mildly reduced, or HFpEF. So they just purposely decided to keep that out of there, knowing that there had been previous research and there was no signals of harm that were occurring.
The issue may be reimbursement.
Oh, yes, and that's one of the questions I was going to have you answer.
It's always reimbursement.
I think the second question that came up twice was about patients who have an infectious state. Is it okay to give IV iron in patients with an active infection going on?
Right, so as I mentioned in that last slide, bacteria, iron is an essential nutrient for bacteria. So if the patient is bacteremic, at risk for bacteremia, or develops an infection while they're getting IV iron, it should be withheld.
Yes.
And short of that, though, milder infections, maybe incidentally picked up infections, I think those are safe to continue, and we'll see emerging data from the pivotal clinical trials that in fact IV iron might even protect against future infectious states, increase the resilience of the system against infection. So while we often are cautious as a community, I think it's mostly restricted to those who are actively bacteremic or at high risk for bacteremia.
Okay, so quick answers. What about cost? Has anybody had any cost issues or insurance coverage issues using IV carboxymaltose?
I published an article years and years and years ago, I mean like in the early 2000s, about treating anemia in these patients. And as long as the patient was anemic, reimbursement was not a problem. Now, with the new data that we have and the approval, I have not had problems. I've not heard any complaints from patients in terms of sending them for IV iron on an outpatient basis.
All right, and for us, it's pretty new. We just got approval by our Pharmacy and Therapeutics Committee to start using it. IV sucrose, we had no trouble getting insurance on, but I'm still waiting to see what's going to happen with the IV carboxymaltose. I think we'll finish with one question here, and this is about, with the 40 to 50% incidence of iron deficiency, what should we be doing in terms of standardized assessments for our patient? I'll tell you that when I do my annual, check their thyroid, check for anemia, check for this, check for that, I've now added on TSAT and ferritin to every yearly assessment. So I am doing it a minimum of once a year, and that's on all of my patients, whether they have a history of it or not. Just like I check thyroid, even if they've never had a history of hypo or hyperthyroidemia, because I find as my patients get older, they start developing thyroid insufficiency. So again, for me now, I'm making it a standard. I don't know if you guys
And these aren't often extra blood draws. These are often can be in conjunction with basic metabolic panels or other laboratory testing that we're routinely doing. One note I realized about ejection fraction is the guidelines have broadened the guideline indication for IV iron treatment to include mildly reduced ejection fraction, because the pivotal trials included patients up to even ejection fractions above 40%, but below 50%. So really the weight of the evidence certainly is with heart failure with reduced and mildly reduced EF.
All right, I think we need to stop because of time. If somebody has a burning question, feel free to come up and speak with the panel. And thank you very much for your attention this morning.
I believe that the exhibit hall is open, so please go enjoy, grab some lunch. We have a product theater. I believe Barostim CVRX is going to be presenting, and there'll be another industry-supported presentation from Medtronic.